Good morning, everyone. My name is Eddie Chang, and I'm really excited to be with you this morning to talk about the topic of trigeminal neuralgia. And with us today is a very close colleague of mine, Dr. Maggie Waung, who heads our trigeminal neuralgia clinic with me. And she also runs our special clinic in neurology for complex diagnoses down at Mission Bay in the Wild Building. But today's focus is really on topics in trigeminal neuralgia. We're going to go over some of the basics, but also talk about topics that I think are very relevant for any center that sees a lot of patients with trigeminal neuralgia. Things that have to do with the differential diagnosis, medical management, and then also what we're very excited about is new surgical treatments that have arisen for treating trigeminal neuralgia. So again, I wanted to thank all of you for being here with us as part of this community grand rounds this morning. And my co-host is co-speaker is Dr. Maggie Waung from Department of Neurology. Maggie, thanks for joining us today.
All right. Yeah, thanks for this. And I'm excited about this topic and presenting these cases today.
So one of the reasons that we have this here is that Joan Connelly led our local trigeminal neuralgia support group, the facial pain support group, and she's been very vocal. This is an article that was written about her story. She's a patient that we ultimately treated with MVD, has been cured for about a decade, actually, from the debilitating facial pain that she suffered. And one of the key things about this is, and it continues to surprise me, how many patients have this diagnosis, but unknowingly. So on the one hand, we see a lot of it, but on the other, there are a lot of questions about diagnosis. There are a lot of people who are being managed without really exploring all the options that are available. And she's been a huge advocate for our group and also advocate for patients with trigeminal. This title here, suicide disease, some of you know that historically it's been known as that because before any treatment options were available, it was oftentimes considered suicide because it was so unbearable. So this is really something that is quite debilitating. So Dr. Waung is actually going to go over some of the background in differential, and then I'll be talking about some of the surgical options for TN.
The reason trigeminal neuralgia is known as suicide disease is the pain is so excruciating, and patients almost have a fear about the pain coming. So that is a huge clue when people are so scared of the pain coming that could be trigeminal neuralgia. Classically, it presents as sharp pain. The pain, though, is short-lived, at least in the beginning. It's paroxysmal, and it's distributed in the trigeminal nerve distribution that covers the face. The other feature is trigeminal neuralgia pain is triggered by innocuous or non-painful stimuli. And in general, even though we know the trigeminal nerve is affected, it doesn't cause any sensory loss. We have three main cases for you today, and we're just going to use those cases to talk about different types of management of trigeminal neuralgia. The first patient I saw, he's from Texas. He's a retired history teacher, high school teacher. He's 72, and he started having pain on the right side of his forehead about a year before seeing me. The pain was described as sharp jabs and just talking for a few seconds, and he really loved to talk, could trigger the pain, brushing his teeth. He had all the typical features, wind blowing across the face. There wasn't any, there's no baseline pain between the jabs, and he didn't have any trigeminal autonomic features, things like tearing of the eyes, swelling in the face that you can see with other conditions that might mimic trigeminal neuralgia. And this is a common feature. He went to see multiple dentists and endodontists because he for sure thought it was a tooth problem that was just affecting the whole face, but they ruled out any dental causes. carbamazepine, which is typically used for trigeminal neuralgia, did completely stop the pain, but then he developed liver enzyme elevations and had to stop it. And then he started on gabapentin, which didn't work as well. His exam was completely normal. So, as you all know, that he has trigeminal neuralgia, and I gave him that diagnosis. Trigeminal neuralgia is a rare disease. It only affects only like 10 to 15,000 people per year are diagnosed. Although, like Eddie said, we seem to see more of it because people just don't know about it. They go to their dentist or ENT first, and sometimes they don't get to us till much later. This patient that I saw, his pain was first started in the forehead, but usually trigeminal neuralgia affects the V2, so around the cheek and the V3 region much more commonly. It's more common in females and tends to occur more on the right compared to the left. And in general, it starts in people who are older. So anytime a younger patient presents, always thinking about other potential conditions like MS or secondary causes of trigeminal neuralgia. I spoke about the sensory changes and the triggers. And then although baseline continuous pain can be present, in my experience, it tends to come on later. So initially, when people first develop the facial pain, they really don't have continuous pain.
Maggie,
Classical.
Maggie, let me ask you a question just real quick. What's your thought, and how do you explain to patients like what is going on in this condition, like where they can have this essentially normal sensory exam, but have severe pain? And how important is that to you in distinguishing this from, let's say, a neuropathic facial pain where they can have sensory loss?
Yeah, that's a great question. And so the way I think of it, and a lot of it is based on the clues of what we know can trigger trigeminal neuralgia, for example, like neurovascular compression, where there's an artery that hits the nerve right as it is entering into the brainstem. And the hypothesis is that that artery is pushing against the nerve and causing demyelination. And I like to tell people it's sort of like when water is dropping on a stone. Just one drop is not going to do anything, but over time it can create a hole in the stone. And the same thing in trigeminal neuralgia, the artery is just beating on top of the nerve. Over time, it wears away the myelin. So it doesn't necessarily damage the sensory nerves, but because the myelin is worn off, then it causes the ephaptic transmission where activation of a light touch, like with light touch, can trigger those pain nerves that are going along, flowing in the same bundle. So
Yeah. I use a similar explanation. Sometimes I describe it as even a short circuit between the different kind of sensory and pain fibers, where you can have an impulse coming down a light touch fiber, but then because of the lack of insulation from myelin, you can short circuit it to a pain fiber. And the demyelination, in addition to the mechanical compression, maybe contributes to that. But
yeah.
Yeah.
Yeah, and that's another feature too, that a lot of people have remissions in pain, and it's completely unpredictable. So they'll start having pain, and then one day it'll just go away. And that I feel like that nicely maybe corresponds with how people might be remyelinating the nerve over time. So yeah, they remyelinate, and the pain gets better, and then the artery ruins the myelin again. So they have this cycle.
Absolutely. I was going to talk a little bit about this MRI and MRI findings here. And thanks for pulling this up because here, as we have listed, this is sort of like the classic trigeminal neuralgia MRI finding that Dr. Waung and I look for. But there's obviously a lot of other forms of vascular compression. But this is really the classic thing that we look for, which is usually caused by the superior cerebellar artery, I would say like 80 to 90% of the time, and then rarely the ICA artery can be compressing as well. And in both these MRI images, this is typically what we see with the SCA or the superior cerebellar artery compression. And what happens is you can have a segment of the SCA that is just a bit too long. And when it is too long, it can form a loop, and that loop can get stuck basically right there where Dr. Waung has highlighted where that compression, and that tends to be a very sensitive part of the nerve because at that area that's called the root entry zone, there's less myelination. It's this transition from the nerve root to the brainstem, and there is just much less myelination there. So that tends to be really important in the pathology of this, that there's naturally less myelin there. It's possible certainly to get compression and TN from the cisternal part, the part that's more distal away from the brainstem, but the root entry zone is particularly vulnerable. And so what you're looking at there is you can see both the left and right trigeminal nerves. The left one looks pretty unencumbered and it's just surrounded by cerebral spinal fluid. But the right one, you can see is actually deformed a bit, and you see the cross section of the SCA. So what we're looking at is just a cross section of this loop of the SCA that's descending down and caught there right at that spot and causing some compression. And this is what we love to see, you know, when it actually is there. Maggie, I see you're smiling because typically when we see this, we can almost, 90% of the time be assured that this can be fixed and treated if patients, proceed to have a surgery for this. So this is something we love to see, which is this kind of cross section of the SCA. And to me, it's a little bit surprising still how often it's missed, in the standard MRI evaluation or we just see a lot of patients. I would say almost 60% of patients still come in with a report of quote unquote normal MRI. No pathology around the trigeminal nerve, but then you just look at this typically Fiesta sequence and it shows it pretty clearly, but you do have to know what to look for. The Fiesta sequence for us is critical for this because it shows that high contrast T2 signal between the nerves and objects that are in the cisterns. And we can clearly see the shadow of the arteries in the nerve in that. So the Fiesta high resolution sequence around this nerve is very important. And standard MRI actually is not actually that helpful. Would you agree with that?
Yes, I would. Yeah, the Fiesta is critical, and most standard MRIs that people come in with, the cuts are just too thick and will often even sometimes just miss large parts of the nerve.
Yeah, agree. There's also one final point here is that it is possible to actually have veins that are not under arterial pressure compressing the trigeminal nerve. And this is less common. There's actually quite a bit of debate whether or not veins can actually cause trigeminal neuralgia. The management of veins that are compressing the trigeminal nerve is very different. We can move and decompress arteries, but with veins, you can move them to some degree, but oftentimes you actually have to bipolar and cauterize and transect them. So the management of it is a little bit different and may have different implications for side effects. So just want to bring that point up.
Yeah, and this patient actually did have what's on imaging looked like there was a compression of the nerve here. You can't see the trigeminal nerve too well, but the artery here, I tried to highlight here, the superior cerebellar artery. And then he also had what looked like a vein that was just in that space. And the coronal view, you could see a little bit better right here. This is the trigeminal nerve root entry zone, and right above it is the SCA. And then here's the vein adjacent to that. And I would say that the sample image is nice because you really could see the artery, but really it's scrolling through the images that really gives you a good, better sense of what the 3D space is like.
Yeah, absolutely. This is a beautiful image. You know, when we see this in the operating room with there's both an artery and a vein, then it becomes a little bit of an art and science, you know, more than science, just like deciding which ones. We always treat the artery, but then there's always a question, you know, do we also take the vein? And in my practice, like if the artery is pretty clear cut, we'll probably leave the vein alone. Again, it's very low pressure and rarely causes any real deformation. So this is primarily about a case, but it really, you know, the classic trigeminal neuralgia case, but that Dr. Waung referred to us, and we work really closely on management of patients. MVD is a very, very important treatment modality. It stands for microvascular decompression. And why it's so important for us is that for the vast majority of these patients, it actually addresses the etiology of the pain. And that means that if you can get rid of the pain source, that the rate of recurrence is much, much lower. This is a Kaplan-Meier plot in terms of the long-term pain recovery, and basically shows that patients that have really the classic kind of trigeminal neuralgia that we call type 1 have much better outcomes over months and years. Our outcomes are about 80 to 90% or the 5 to 10 year time point, slightly better than the series here. The long story short is the more classic, the more typical the trigeminal neuralgia presentation, the better the outcome. And because of that, when we see quote unquote atypical cases where, you know, you have sensory loss or chronic burning pain, it really sort of raises a little bit of red flag, you know, on whether or not someone would benefit from a microvascular decompression, even if you see the imaging findings there. So in this particular series, patients with type 2 trigeminal neuralgia had much worse outcomes. And it's not zero, it's far from it. And many of these patients really have no other option. So sometimes we still proceed with MVD, even if the outcomes are much less because there may not be other options. So this is a little bit just about the MVD expected outcomes. And next slide. This video that we made basically is just going to walk through a little bit of the anatomy. And here's a 3D model of the trigeminal nerve. As you know, it's got 3 inputs from the ophthalmic, maxillary, mandibular branches, V1, 2, 3. That's a animation of the trigeminal nerve where it's coming out of the pons. And like I described before, the superior cerebellar artery sometimes is just too long. And when it happens to just loop down, it can get stuck right at that spot where the root entry zone. And as Maggie alluded to earlier, it's that wear and tear. It's that water, it's that pounding artery, the water on the rock that is dripping on it and just, you know, causing demyelination and mechanical pressure that causes kind of like a sore spot on the trigeminal nerve. So one of the things that we think about doing is just really trying to relieve that by, you know, moving that artery off that. And that's what the microvascular decompression procedure is about. So yeah, perfect. So the surgery involves making a small, about 1.5 to 2 inch incision behind the ear. And we drill a hole through the bone, and that bone is replaced with bone cement in order to just completely replace that. And we use a microscope to find where the artery is compressing the nerve. There's no cutting of any brain. We're not going through any brain or nerves. Though technically this is brain surgery, we're not cutting through any of that. And the key in traditional maneuver is to place a small pledget or a padding of Teflon between the SCA and the trigeminal nerve. So that's what it looks like. And the Teflon looks literally like a small, tiny piece of cotton. This is what it looks like after decompression. Under the microscope, you can see the trigeminal nerve here, actually on the left. You see a Teflon pad that's placed in between that and the SCA artery loop that is sticking out to the right. At the time of decompression, it was looped underneath the trigeminal nerve. And here it's been moved out and then insulated. So it's not enough to just insert a pledget between the artery and the nerve. You actually, in most cases, need to actually move and transpose the SCA to a different location. You actually have to get it out of that that notch where it's stuck against the root entry zone. So you actually have to dissect it out so that it's free. And I oftentimes think of that being the critical decompression, not the Teflon. Teflon is a way of just keeping it away from the nerve. But the real decompression is actually the dissection of the artery and removing it from the nerve itself. So as I alluded to, the MVD is not like 100%. It's pretty good, 80 to 90%. And again, people who have the classic trigeminal neuralgia are the ones that have the best outcome, but there is a recurrence rate that can anywhere between 1 to 5%, and that's across all series. And there can be many reasons for this. Sometimes it's because, the original decompression was really not at the right spot. We rarely see anything like that in our practice, but there are some things we just don't understand about the pathology where the pain can come back despite being pain-free initially for months or years. There could be ongoing inflammation around the nerve that we can't see on the MRI. The things that we worry a bit about are adhesions and inflammation related to the implant itself. So one of the things that we always, get imaging if the pain recurs after an MVD is because we're looking out for things like a Teflon granuloma. And Teflon granuloma is basically an inflammatory response to the Teflon as a foreign body. It's pretty rare, but does happen every now and then. And so this is from this report from Sharma 2015 that basically shows the hyperdensity on the CT below and also some of the imaging features on the MRI above consistent with this inflammatory response. And under pathology, you can see that the Teflon becomes infiltrated with macrophages and other inflammatory elements, which ends up becoming a pathology of its own. So the treatment here became the pathology, and that's something we want to avoid. So we've been really thinking about actually how to move the needle on this, because when you see this, it's actually quite dangerous to remove this. There's a higher rate of trigeminal nerve injury when you try to remove the Teflon in this instance, and possibly injury to the artery as well. So we've developed a technique here called the sling transposition. And so this was really something that I came up with one of our former residents, Dr. Ethan Winkler. And this shows you essentially how this goes. This video is sped up a little bit, but all those pulsations are cardiac heartbeats. And you can see the superior cerebellar artery there looped down right on the trigeminal. And as I mentioned before, dissecting it from the trigeminal trigeminal nerve is the main part of it. It's not really the Teflon. But we really started thinking, are there better ways to do the decompression? And is there a way that we can do this in a way that we can essentially have nothing, no foreign body and nothing touching the trigeminal nerve? So what you're seeing here is a small piece of pericranium. Pericranium is just a small fascial layer that lives above the bone. We harvested it on the way in. And then at the time of the decompression, once the artery is off the nerve, I'll take that down, take a small strip of it, really only about 1.5 centimeters long and about 4 millimeters wide. Under operating microscope, we'll put a small nylon suture around it and anchor it to the tentorium. The tentorium is the meninge, the dural membrane above that you see there that's separating the posterior fossa from the supratentorial compartment. That's the tentorium. And just tying some knots under the microscope. It does take a little bit of a learning curve to do this, but it really is an elegant and effective way of keeping the artery away from the trigeminal nerve. And I usually supplement this with just a drop of fibrin glue on top of the SCA. So there you can see that the trigeminal nerve is now completely decompressed, and there's no Teflon. There's nothing that we have to put in there.
That's very cool. How do you have enough cases to know if there's less recurrence rate with these slings?
It's, we're accumulating our case series, and I think we have at least, about 40, 50 of these cases that we're going to compare in a case match way against people who've had the traditional Teflon decompression. It's going to be hard to know because the Teflon itself does really well. So I think we're going to need more numbers. But what it gives us is really the peace of mind that if someone does have a recurrence, that we don't really have the suspicion that it's like the Teflon there or something else. We just have peace of mind that that it's nothing that we put in that is continuous, something intrinsic to the nerve. Patrick had a question here. Can anything else be used beyond Teflon that's less inflammatory? For interposition, you mean in terms of putting something in between? Not really. And the Teflon, again, is not that inflammatory, but for some people, it really can be. And so our basic algorithm now, Patrick, and this is a wonderful question, is just that if we can avoid using the Teflon, we'll do this transposition if it's favorable. Not every case we can do transposition. As you can see, to do the transposition, you have to be able to completely mobilize the SCA. And there are certain cases where that's just not possible. So the current algorithm is we go in hoping that we can do the sling transposition. And if that's not possible, then we'll do the Teflon.
So this patient that we talked about earlier, I sent to you, and he got a sling transposition. And this is a message that he sent me afterwards. He's very happy, barely even talked about his trigeminal neuralgia. He's a UT fan. He's obsessed with the UT Michigan game. Unfortunately, we know how that turned out, but yeah, it was great. And a lot of people are very grateful after the surgery. So it's always nice to see. The second case I have is a woman, she's 63 and had retired. She was a golfer. And she came to me with she was initially referred to you. And she was a little peeved about seeing me because she thought I would be the surgeon. And her husband was also upset. And I had a good talking to for the first 10 minutes. But, when she was finally able to give me the history, she let me know that she had polycystic kidney disease and had a transplant. And the reason her husband was so annoyed was that he was the one that donated his kidney to her. And he just wanted her to be as healthy as possible. But when she developed this left-sided facial pain, after she had fallen on the left side of her face, it really debilitated her, and she wasn't able to do anything all day. And she had the typical features of trigeminal neuralgia, that's paroxysmal, but she also had some baseline pain in between, and no triggers, none of those cutaneous triggers. And she had some trigeminal autonomic features, the tearing and congestion over that left side of the face. And another thing that was concerning was she said maybe there was some blurry vision in that left eye. And because she was on immunosuppressives, her kidney physicians didn't want her to start carbamazepine or oxcarbazepine. So they put her on gabapentin, which was not helpful. And actually duloxetine, the SNRI, was more helpful for her pain. When I examined her, it was clear she had a little bit of eye misalignment on that left side compared to the right, and decreased sensation on the upper lip, along with some allodynia there too. And so, just I knew that she would have an atypical case when she was so eager to see Dr. Chang in neurosurgery. And I was just dreading, giving her the news that we needed to do more workup. And the reason she was very keen on seeing Eddie was that the report that she got, we talked about how a lot of times the report misses the compression. Well, it specifically mentioned that on the left side that she had the SCA abutting the cisternal segment of the left trigeminal nerve. So she thought for sure she would benefit from the surgery. But
So, Maggie, just to clarify on that too, I think sometimes that really is difficult, and there are so many patients that have trigeminal neuralgia that are like underdiagnosed or misdiagnosed, right? That never get to us, right? That are easy fix with MVD. And then there's this other group, which is these patients that do find out that they've got it or something like it, and then they see everything about how the MVD can be so effective, like almost like a miracle to treat that pain. And then they come in with the hope and expectation that that's going to be available, kind of just like what you described. And when it's not the case, those are difficult for both of us, like, really setting the expectations and really doing the work. Because I would say 99% of the time, someone in the outside looking at that presentation that you just gave in that MRI would have proceeded to an MVD. And so it does take a lot of work to figure this out when those red flags are there.
yeah, because there can be mimics of, well, both there can be mimics of trigeminal neuralgia, and there can also be secondary causes of trigeminal neuralgia, like tumors in the cerebellopontine angle there. Usually they're benign tumors like meningiomas, acoustic neuromas, cysts, but sometimes they can be malignant. And then MS is another important cause and another reason to get brain imaging in all patients with trigeminal neuralgia, because MS can mimic trigeminal neuralgia and the treatment is different. It's completely different. Other more rare causes could be connective tissue disease or deformities of the skull. And so this case highlights some of the reasons to consider a secondary form of trigeminal neuralgia, which anyone with cancer, other cranial nerve deficits like hearing loss, or anyone who has bilateral symptoms, it's probably less likely to be trigeminal neuralgia. And then sensory loss in the face, or people who might be immunocompromised and susceptible to secondary causes like tumors or inflammation. And then moving on from secondary causes of trigeminal neuralgia to the differential mimics of trigeminal neuralgia that don't have that classic presentation of the shocks of pain, but they still might have severe facial pain. A lot of times this is called atypical facial pain or persistent idiopathic facial pain. And so I call these patients trigeminal neuropathy, people who do have sensory loss in that area. Usually, most commonly, it is post-traumatic, but other causes can actually damage the nerve. And I feel like these are less of a demyelinating problem and maybe perhaps more of an axonal damage to the nerve. And then it's always important to keep in mind, too, that there's some rare primary headache conditions, the trigeminal autonomic cephalgias, that can also cause brief pain, paroxysms of pain. Although usually these are more in the head, in the forehead, sometimes they can present in the cheek. And that's also something to consider because the treatment, again, is very different. Use indomethacin or lamotrigine for these, and then some other second inflammatory causes. Okay, so here's an audience response question. What would you do for this patient that's come in? Send a referral to Dr. Chang for consideration of MVD, check for their labs like autoimmune markers, review images, or obtain new imaging. Okay, great. Great, this is good. So kind of a good mix. People aren't too keen about sending to neurosurgery quite yet and wanted to do some additional. So, I did send additional labs, in the clinic. I could do more than one step. But I also reviewed the imaging that she already had. She had this MRI from January that showed the possible compression of the SCA. But then when I was looking at her sinuses, I noticed on the left side that there's some fuzziness that looked weird. So I immediately went to neuroradiology to look at this more carefully. And here's some other images. So here you can see right here in the maxillary sinus, it looks like there's something that's disrupting some of the fat planes of the face. And then here on the contrast study, there's some contrast enhancement right below the orbit, exactly where she was telling me on that left side of the face. And she'd actually gotten a repeat in MRI after the first MRI before she saw me. And now you can see this mass in the sinus is much bigger. Here you can see it's starting to creep into the orbit here. And then on the CT, you can see some discontinuity of the bone. This is really concerning. So I did repeat imaging, which showed, even more progression of this mass. And so I did refer her to a surgeon. She actually already had a surgeon, but it wasn't Dr. Chang. It was an ENT surgeon, Dr. Reed. And she underwent biopsy of this lesion and was found to have a fungal infection. And, eventually went to debridement. And this fungal infection, and you could see, it's hitting right where the infraorbital branch of the trigeminal nerve would be coming out of the orbit there. So that explained most of her symptoms. So after the surgery, she was able to wean off her Cymbalta, did great, was very happy, got back to her golf game, although she still has to take voriconazole indefinitely.
Maggie, that's a really interesting case. And I think one of the learning lessons from this is that when you're looking at the MRI, that just looking at that cisternal component in the brainstem is not enough. You really have to think about the length of the trigeminal nerve distribution, everything from, the brainstem out to the different distributions, mandibular, maxillary, ophthalmic, even, to really rule out any peripheral etiologies. And I don't think that we do that enough. So I think it was, quite incredible that you picked this up. Because like I said before, 99% of the time, I bet this patient would have had an MVD and undoubtedly would have continued to have symptoms without really understanding what was going on here.
Yeah. And I think it was helpful because she did have so many red flags. But sometimes people don't have red flags. They can present like classic trigeminal neuralgia. And so even then, although less likely, you could have a branch that's affected. So, and I, not an expert at looking at all the different branches of the trigeminal nerve. And it's luckily we have an amazing radiology team who's working on MR neurography of the facial nerves, which can be a major challenge. So it's great to be able to partner with them and run up and see them.
Yeah, absolutely. Okay, let's go on to the next case here.
Okay. So the next case is a patient, and he is nice. We were able to see him, I think, on the same day. He is 48, and his facial pain started on the right in the upper gum with some triggers of just wiping the nose and brushing the cheek. He also saw a dentist. and who didn't find anything. And he had a relapsing, remitting course. And this case was challenging because even though it was relapsing and remitting, when he did get the pain, it was just very severe and really interfered with his work. And this is a guy, he only gets like 2 or 3 hours of sleep a day because he just works all day. And the pain just was not fitting with what he wanted to accomplish. He had a normal exam, and his mom sent him some Chinese herbs that he tried, but they didn't work for him. So, and we had recommended imaging, and we didn't see any compression at the trigeminal nerve root entry zone on the right side. And there's nothing secondary that we found either on imaging. So because we didn't find anything surgically, always we try to tell people that we do want to start people on medication first before moving on to surgery. And I think this is twofold. One, sometimes people can do really well on medications, especially people who have the remitting trigeminal neuralgia, because they just need a brief period of time where they're on carbamazepine or oxcarbazepine. And then once the pain remits, they can often taper off. And the second reason is that people who have trigeminal neuralgia almost 100% respond to the sodium channel blockers, carbamazepine or oxcarbazepine. And that's another red flag symptom if someone has tried these medications and their pain doesn't respond. And I think that also speaks to the nature of the disease, that this is really a myelin problem. So a lot of times, if people cannot be on oxcarb or carbamazepine, it's due to the side effects of that. And so then you can use treatments like gabapentin, pregabalin. Baclofen can be a good adjunctive agent. And then sometimes the TCAs, the tricyclic antidepressants. And some of the newer medications that are used, what's emerging is lacosamide or Vimpat. And that's been a nice tool because it is different configurationally compared to oxcarbazepine and doesn't have the same side effects, but seems to have a similar functional effect. And then you could try targeted nerve blocks too, and Botox is being looked at. There's not many medications in the pipeline for trigeminal neuralgia, I think in part because it is a rare disease, but Besimglurant the clinical trials should be coming out soon as a mGluR5 negative allosteric modulator, and then vortioxetine, which is a sodium channel specific NaV 1.7 blocker. For this patient, he was Han Chinese, so I went ahead and sent the HLA-B 1502 typing in case I wanted to use carbamazepine down the road. But in the meantime, I started him on oxcarbazepine, which doesn't tend to have the severe skin reactions, the Stevens-Johnsons that we worry about. And unfortunately, we weren't able to get the oxcarbazepine up high enough. So he went to an outside ER for a pain flare, where they were really aggressive, and they gave him a cocktail of IV prednisone, Vimpat, lacosamide, and Dilantin, which helped. And he was discharged on this cocktail of medication. But 3 weeks later, as he was tapering off the prednisone, he developed this diffuse rash in the trunk and extremities. And we were able to get him seen by dermatology here. And he's diagnosed with a drug eruption, probably due to phenytoin. And he did have some systemic abnormality, liver enzyme abnormalities. So DRESS was very concerning. So we immediately stopped the phenytoin. But again, the pain is so severe, he was just very afraid of coming off any more of the medications than he had to. And so we sort of started new medications, and it was really just kind of very touch and go for a while. He was even putting topical benzocaine on his gums every 5 minutes. And really, we had difficulty because we maxed him out on the oxcarbazepine, maxed him out on the Vimpat. And he's still having a substantial amount of pain. And then, as many people with oxcarbazepine do, he developed low sodium levels and started having side effects due to that. At this point, I had to turn back to Dr. Chang and think about other treatment options for this patient.
So this is really one of the, I think, tough cases, right, where you've got a normal MRI, you've done this exhaustive imaging evaluation, and but still, patient has like typical trigeminal or mostly typical trigeminal neuralgia symptoms. And when you said non-surgical earlier, you meant really like not a clear SCA vascular compression etiology that we could see there.
Right.
So when we think about the surgery, then we sort of then start thinking about like other options that aren't so much like treating a vascular etiology, but actually the strategy now becomes around deafferentation. Like, how do we desensitize the nerve? How do we injure it in a way that can actually reduce some of the sensory processing with that? So there are other treatment options to do that. And we're going to go through some of those here as well. And it's really important to go through that process with the medications first, because in some ways these are more palliative. The recurrence rate for pain is relatively high, and none of these are in any cases really considered to be like permanent fixes. That can happen occasionally, but we counsel patients that the deafferentation strategy is a way that you can temporarily desensitize, numb the nerve in order to help with the pain. And so we're going to go through some of those. So one of them is the percutaneous radiofrequency ablation. So this is a outpatient procedure. It takes about 30, 40 minutes in the operating room. And the principle here is to use heat to burn the nerve at the trigeminal ganglion in Meckel's cave. We get there through the foraminal valley. So this is the sedation for this is basically awake, asleep with the anesthesiologist, where when the patient's asleep initially, we introduce a probe, a needle, up to the level of the Meckel's cave through the foraminal valley using C-arm guidance. And we have them awake for part of this procedure because before we do the burning of the nerve, we actually we map the ganglion using a small electrical stimulation. The reason we do that is that we want to know if we're in the V1, 2, or 3 distribution of the dermatomes. And the reason why that's important is that if you do this ablation there, and let's say you burn the V1 distribution, but the pain is in V3, then it's not going to cover the pain. So it's relatively important really to confirm the site of the probe tip before you do the radiofrequency. And it does take a special anesthesia team in order to get patients asleep enough to do this without pain, but then also awake enough to do the testing. And then we have them asleep again. Once we confirm that we're in the right dermatome of the trigeminal ganglion, that we can go ahead and burn it. And that's usually at about 85 degrees for about a minute and a half or 2 minutes. And this causes a thermal ablation. And the theory behind this is that this heat is selectively destroying the A delta and C nociceptive fibers, while preserving the other touch fibers. But I don't think that that's necessarily true. And the reason is that the patients that have the numbness, basically have knocked out the light touch, are the ones that really are the ones that have the best benefit and have the longest pain-free survival, meaning that you really do have to deafferent the nerve altogether in order to get the best effects. You can certainly see folks that have normal sensation and are pain-free, but that's rare, and they tend to have higher rates of recurrence. So something about actually desensitizing the nerve turns out to be really important. So if you look at the Kaplan-Meier of people who've had the radiofrequency, it's about at about 10 years, there's about 80% still. So it's a very, very effective treatment. About 80% of patients can still have that. And it really comes down to the degree of deafferentation. Next. This is a Kaplan-Meier that basically shows the pain-free survival based on whether someone has that sensory loss. And you can see that the folks that have that sensory loss are the ones that are the upper two curves, and the ones that don't are the lower. So something that we counsel patients about this is that that sensory loss is a good thing. It's not a complication of the procedure, it's something expected, and it's a really important positive prognosticator of long-term outcome. The other treatment option, which is also outpatient, non-invasive, is the Gamma knife. It's a really important modality for us to be able to treat this. This is oftentimes done equally important as the percutaneous radiofrequency. And interestingly, Gamma knife, there is a higher proportion of patients that can still have normal sensation despite being pain-free. Only about 20 to 30% of patients will be pain-free, will have that's induced numbness with the SRS. So basically, patients that can get by, on medications, I usually recommend for the SRS, because there is a slightly improved benefit in terms of not having as much numbness while still becoming pain-free. And we usually use 80 gray at the root entry zone of the trigeminal nerve, maximum dose. And then for repeat procedures, around 40 to 50 gray. And the whole point of this is to reduce the brainstem dose. Next slide. One of the things that is really important about this one is, unlike the MVD, unlike the percutaneous radiofrequency where the effects are immediate, Gamma knife, sometimes it can take months to kick in. I have seen cases take up to 9 to 12 months in order to kick in. So we don't really treat or retreat patients after Gamma knife until we've really seen that they've failed it after about a year. And you can see that radiosurgical effect can just take some time. The Kaplan-Meier on the right basically just describes, the pain freedom at about 10 years is about 30%. So it can come back, and it's not necessarily a permanent solution, but the good news is that it's outpatient and can be repeated. Next slide. The last thing about this is that the people who have the new sensory numbness, basically paresthesias, that kind of thing, usually very well tolerated, are the ones that have the longest pain freedom. So again, it's really not a complication. It's actually a positive prognosticator when people have that numbness after the procedure.
And you found that this can be helpful in patients with MS-related trigeminal neuralgia.
Absolutely. Yeah. Both the percutaneous radiofrequency and Gamma knife are treatment of choice for patients with MS. And again, if someone's getting by on the medications mostly and can last that couple of months, then we'll recommend the Gamma knife. If someone is really sick, they can't eat, if they're hospitalized, very, very ill because of the trigeminal, then we'll usually do the radiofrequency and burn the nerve. And just a quick comment, we do have both CyberKnife and Gamma knife at UCSF, but we prefer to use the Gamma knife because it's a lot more, it's a lot more precise. The physics of it is more conformal in terms of protecting the brainstem. And we've noticed in patients that have had CyberKnife, there's many more cases of anesthesia dolorosa, which is very rare after the Gamma knife. So here we typically use the Gamma knife instead of the CyberKnife to treat trigeminal pain. Last thing I'm going to really just mention is there are cases where we do MVD and either because the patient strongly, is asking for this, and there's something questionable that we see on the MRI. And so we do proceed with an exploration. And one thing that we've developed here with the neuromonitoring team, JP Clark and others in our amazing neuromonitoring group, is to be able to map out the trigeminal nerve. And we do this by using antidromic stimulation. So you can actually put a probe on the nerve during the surgery and actually map out the different dermatomal distributions so that you can selectively injure, usually by just pinching parts of the trigeminal nerve with microforceps, and that causes a rhizotomy at the trigeminal nerve. Next slide. So this shows an example of a case where a vein was decompressed with Teflon. You can see that, but we weren't really convinced that that was enough. So we use this ball electrode to map the different dermatomes of the trigeminal nerve, and we can actually selectively diaphragm, selectively ablate parts of it, and that helps a lot. So there are a lot of things that we can do to even make the MVD more selective and target parts of the nerve to treat. And we only do this deafferentation if we're not convinced that the vascular compression is the problem. So here's a case where we did put Teflon, but we also did a rhizotomy as well. So we're basically at time, and we're going to summarize here. Maggie, if you could help summarize some of these points.
Yeah, sure. And so trigeminal neuralgia is a clinical diagnosis. But when you do make the clinical diagnosis, it's important to get imaging to rule out secondary causes, and to first, start medication with either carbamazepine or oxcarbazepine, plus or minus the adjunctive treatments. And then consider, once those medications don't help, maybe targeted nerve blocks or neurosurgical options.
Yep, great. And we're going to just take a couple of seconds to address some of the questions that came up. One question was, with a sling, are there any mechanical concerns of attaching the artery to the dura? No, we've never seen anything like that. And it's a wonderful question. One of the things also that we were quite careful about, and something we've looked at across cases, if there's any vascular compromise, something that we do during the surgery is just make sure there's no kinking of the artery in the new position, to just make sure that there's good blood flow. And it's a very loose sling. It doesn't take a lot to hold it there, and it's not very tight. The pericranium is just loosely put around the artery, and then it's attached there, but not much of a concern there. And it's been very safe. Sometimes technically challenging, but perfectly safe. And then a question from Dr. Clark is there any significant functional impact when patients develop the sensory loss? Generally, no. Some people will notice that they bite the side of their cheek more a little bit. They have difficulty chewing on that side. The one time that it can be a problem is if the sensory loss is in the V1 distribution, in the ophthalmic distribution. And the reason that is because the corneal reflex to the eye can be attenuated from that sensory loss. So that's why for us, doing this trigeminal mapping is very, very important, both for the percutaneous radiofrequency, but also for those intra-op rhizotomies, that you really just don't want to get V1 numbness, because that corneal reflex, if it's lost, people can develop keratitis around the eye, primarily because they blink less and the eye dries out and it can get infected. So great question, Dr. Clark. We really do try to avoid getting sensory loss in the V1 distribution, but in the V3, it's generally well tolerated.
Thanks for organizing this talk. And I just want to highlight how great it is to be part of this team here at UCSF, which really is multidisciplinary. We get to work closely, neurology and neurosurgery, and then we also have colleagues in pain medicine, in the headache clinic, and then of course radiology and radiation oncology here as well.
Thanks, Dr. Waung, and thanks for doing this grand rounds with me. These are really great cases that you brought, and I also want to thank all of the people in the community that were able to join us today, both from our department and our friends and affiliates. Really look forward to having you on our next community ground rounds. And thank you very much for joining us today. Have a great one.